Thank you very much, and thank you very much for the invitation to come and speak at this very interesting meeting. And well done for sticking out as long as you have done. So, just to show you that I am paid by at least 2 companies that have a BTK inhibitor. Okay, so what I'm going to discuss briefly a little bit on BTK inhibition, which is well known to this audience, I guess. A bit on ibrutinib, then we'll talk about CLL specifically, show the data in CLL, the published data in CLL, touch on combinations. Then we'll move to mantle cell lymphoma, talk a little bit about long-term toxicity, data that you may not have seen, show you stuff on lymphocytosis, and then we'll mention the other BTK inhibitors that are currently in clinical trials. I can only show you data that is out there. I can't show you anything on the bottom one there, ACP196, which is the latest BTK inhibitor that's just entering the clinical arena. Okay, so BCR signaling, as you well know, is critical to cell proliferation, differentiation and survival, and for CLL and some of the lymphomas, they chronically signal down this pathway, so if you can interrupt it in any way, then that leads to apoptosis and cell death. And as you can see, there are a number of potential targets down that pathway, and BTK sits in the middle because this is a Janssen slide, so that's the biggest thing you see on that slide, obviously. As well as affecting that has effects in other pathways as well. And the one on the right is the interesting one. So CXCR4, which you remember, that's what plerixafor targets. So by interrupting that pathway, that stops the cell from being sticky, essentially. And so that's why you see the B-cell migration. And I'll show you a little bit on that a bit later on. So here's ibrutinib. This is the first oral inhibitor of BTK. Once daily, highly potent, and irreversibly binds to the 481 cysteine in the BTK. Here's the binding, 481. That's important because I'll show you later on some mutations are being seen here now in patients on this drug. And very good BTK occupancy with once daily oral dosing. That's what it looks like. That's a picture of the original BTK on my desk because the company didn't have any pictures of it. It's now changed colour, it's now white, so the current stock is white, which is far more appealing to patients, I think, than grey. And here's the phase 1 trial. So this was a surprise. So this is given to patients with refractory B-cell malignancies, lymphoma and CLL. And as you can see on this waterfall plot, some really quite impressive responses to a very heavily pre-treated group of patients. And you can pick out the mantle cell patients in green and the CLL patients in blue who do particularly well. And these responses were very durable. And that's what led on to phase 2 studies, and we'll talk about CLL first. So here's the summary of the data in CLL, and the top 2 are the industry studies. First one, ibrutinib alone in relapsed refractory patients, and a subsequent cohort of patients who are treatment naive. And I'll show you this data in a little bit more detail in a second, but you can see some incredible PFSs in frontline treated patients. And then this is the randomized trial recently published of ibrutinib against ofatumumab. Again, I'll show you that in a bit more detail. And then we've got other studies looking at combinations, and it won't surprise this audience to know that any combination you can think of that could be given for CLL and lymphoma is now being given in trial in combination with ibrutinib. And I'll show you some of that data as well. So here's the first study I showed you, and this randomized patients between 2 doses of ibrutinib, 420 milligrams and 840 milligrams, and it included a third cohort of high-risk patients, as defined by Cytogenetics, and there was a treatment-naive group, which I won't show you particularly. Here's the overall adverse events, so very well-tolerated drug, and the thing to emphasize here is, whilst you see high incidence of diarrhea and fatigue, these are very transient, and from a patient's perspective, very minor. So diarrhea, for example, patients don't even necessarily tell you about it. It's self-limiting. It starts at about a week on drug and then disappears quickly. And here's the overall response rate in that first study, and the surprise was this lymphocytosis. Now, of course, if your lymphocytes go up, then in CLL world, you have progressed. So the definitions of response in CLL had to change as a consequence of this and the other drugs we're going to talk about in a minute because of this lymphocytosis. But there's a response, overall response rate, and then this CLL PR with lymphocytosis. And you can see it was equivalent between the 2 doses, so this is the dose that was taken forward. And this is another thing that you see with ibrutinib, this increasing incremental response with time. So these are the patients with the lymphocytosis, and the partial remission slowly going with time, and this is the incidence of CR/PR. So you stay on the drug, and the response gets better. You get a relatively quick response, but the median time to best response is a way off. And that's the same in lymphoma as well. So it's important to remember that you need to stay on these drugs if the patient's well. Certainly if they've got stable disease, you stay on it because they may subsequently get a better remission. This is broken down by cytogenetics. So whilst the 17p deleted groups do worse, they still do very well if you put that in context with the other therapies that we have had in the past. Here's the RESONATE trial, which I'm sure Pete Hillman showed you yesterday, comparing all ibrutinib against IV ofatumumab. Remember, this is a licensed drug for CLL at this dose, hence the design of the trial. And subsequently, there was a crossover, not initially when the trial started, and just one slide to show the very significant difference in progression-free survival between the ibrutinib and the ofatumumab, and that still stands even when you take the crossover into account. Just one slide, two slides on combinations. So, as I said, ibrutinib in combination with standard regimens, and with bendamustine rituximab is very much becoming the backbone of studies now in lymphoproliferative diseases. And here's the overall response rate in patients treated with bendamustine, rituximab, and ibrutinib. Again, heavily pretreated group of patients, very high response rates. And here's the adverse events. Neutropenia, I mean, this is not dissimilar to what you see with bendamustine rituximab. So when you add ibrutinib, you don't see much more diarrheas there again, but again, these are transient and modest. As single agent in upfront treatment, I'm just going to show you one really quite impressive curve. So there you go, that's the PFS, really quite remarkable. So one patient's dropped off. So using this drug frontline looks to be extremely impressive. Whether that's affordable or not is a whole different question. So moving from CLL to mantle cell lymphoma, moving to a more interesting disease, if you like. So following on from the phase 1, the phase 2 in patients with mantle cell lymphoma, published here in the New England Journal of Medicine. Here's the key data. So 70% response rate in a relapsed, refractory, heavily pretreated group of patients. And again, just with CLL, you see this slow increase in response. So you need to stay on the drug. This is not like chemotherapy. If you give people 2 or 3 cycles of treatment, it's not working, you don't stop, you stay on the drug. And you can see the improvement in complete remission rate. It's quite impressive there. This is looking at the patients in that trial broken down by characteristic. And as you can see, there is no group that does badly. So however you want to cut the data, whichever bad prognostic group you wish to look at, be that high-risk MIPI, be that high bulk, be that blastoid variant, be that refractory post-transplant, it doesn't matter, the drug works in every scenario. How long it works in those scenarios, we don't know, but at least up front, it works in all of them. And there's the progression-free survival curve, again impressive, as is the overall survival curve, bearing in mind that this is a heavily pretreated group of patients. In fact, if I put an allograft trial up next to that, it wouldn't look completely different. Okay, now what about combinations? So in mantle cell lymphoma, being a rare disease, there isn't that much data as yet. This was presented at ASH, and I'm thankful to Michael who let me have a couple of his slides. So this is ibrutinib plus rituximab in mantle. This was phase 2, a single center study, looked at 50 patients, and classic definition and no prior therapy upper limit. So these were heavily pretreated groups of patients again. Here's the adverse events, less of a leukocytosis, but otherwise the side effect profile very much the same as single agent ibrutinib. And again, as I said, much the same, diarrhea, fatigue, but all very minor, nothing new. Now, what was interesting is there's been some in vitro data to suggest that ibrutinib and rituximab is not a clever combination, that one might antagonize the other. But actually in the clinic, that's not the case. So if you look at the overall response rate here, well, that's complete remission rate, that's the overall response rate. Completion rate is 40%, so you've almost doubled the response rate in this group of patients. So adding rituximab to ibrutinib does work. Now, this was a big relief for me because, as Christian showed earlier, we're going to have a frontline study in the UK of IR versus R chemo, so I was quite pleased to see this. The other thing he showed was that depending on how proliferative your mantle cell lymphomas, your response is different. So the more proliferative, the less likely you are to get a response. So that's different to what I've just shown you in the study, the upfront study as a single agent. There's a waterfall response, and the patients that did badly were, I guess, what you might expect patients not to respond. But as I said before, that didn't play out in the previous study, but he's found that if you've got high Ki-67 and blastoid variant, you was a tendency not to respond as well. Nonetheless, very impressive response rates. And there's the progression-free survival on the left, and you can see when it's broken down by proliferation rate, the higher your Ki-67, the less likely you are to do well. And you can add ibrutinib to CHOP. This recently published. Now, this wasn't in. Some of these patients had mantle cell lymphoma, but again, it was just showing that adding ibrutinib to this combination worked well. Here's the overall response rate. So this is a variety of lymphomas, including some mantles. It wasn't broken down by histology, and you may or may not know there's an R-CHOP with or without ibrutinib study running at the moment in diffuse large B-cell lymphoma, but showing that you can do this quite nicely. Now, what about long-term toxicity on this drug? This is data I presented at EHA this year, and the reason I'm showing you this is this gives you some data on long-term. I can show you this because this manuscript is in press right now. So if you follow this, that's that first group of patients at 27 months median follow-up now, a quarter of the patients are still on the drug. So that relapsed refractory, heavily pretreated patient population, at over 2 years, a quarter of the patients are still on drug. And the commonest reason for discontinuation is progressive disease. Now, what I haven't got for you to see, and this has recently been published, is the outcome of patients who fail off the back of this. And it's quite clear that if you relapse after ibrutinib with mantle cell lymphoma, you do spectacularly badly, and there aren't any particular regimens that look to be active in that situation. Now, bear in mind, these patients are heavily pretreated. So relapsing after you've failed essentially all conventional therapies, have ibrutinib, and then you can't rescue, is okay. Now, that might not be okay if that translates to earlier on in the treatment algorithm. We don't know that yet. What about long-term safety? So here's infections. One of the issues, if you take out BTK, do you get long-term issues with your immunoglobulins, for example, which is what you see with Bruton's disease. And after 6 months, you can see the incidence of infections actually falls. And this is exactly the same in CLL as it is in mantle cell lymphoma. And the immunoglobulin levels actually aren't affected whatsoever. So you don't see long-term issues with infection. And again, in CLL, you'll see the immunoglobulin levels actually rise when you're on this drug. The one thing to mention, though, is bleeding. Bleeding is not a problem, but it's an issue with ibrutinib. About 5% of patients will have significant bruising or bleeding. It looks very like it's an aspirin-like effect, if you like, as far as you perceive it clinically. Patients get large bruises, but it's very important to remember that if patients are having any kind of surgery, because you need to stop the drug for at least 5 days before surgery and 5 days afterwards, because they will bleed quite significantly if you don't do that. Lymphocytosis. Now, lymphocytosis you see in patients that go on ibrutinib, and in CLL you see that almost always. In mantle cell lymphoma you don't see it always, and it struck me when I did the phase 2 study that I only saw lymphocytosis in patients that had bone marrow involvement. Nobody believed me. It took me 2 years to persuade Pharmacyclics to let me look at the data I've just shown you, and here it is, and we just published this in the British Journal of Haematology. What I'm showing you here is the lymphocyte count measured at every time point in all of those 111 patients treated with ibrutinib. 70% of these patients are responding, remember. Only 30% of them get a lymphocytosis. The blue line are the patients who have no bone marrow involvement. So if you have no bone marrow involvement, you get no rise in your lymphocyte count whatsoever. And remember, 70% of those patients are responding. If you've got bone marrow involvement, you see this lymphocytosis. Now, it's important to remember this because some people might assume that you need to get the lymphocytosis and that's a surrogate for response, and it isn't. So you're only going to get that if you've got marrow involvement. If you don't get that, don't worry about it. And the other piece of advice I'd give you is do not look down the microscope at those cells in the circulation because they will scare you to death. These patients get admitted to hospital with query acute leukemia. They look very, very angry, these cells, but you've just got a steady nerve and slowly they will fall. And there are no clinical sequelae to that. You don't need to reduce the dose, you don't need to leukapheresis, you don't need to do anything else, just steady nerve. Now, there are other BTK inhibitors, and this is a very attractively coloured Japanese BTK inhibitor that Gilles and I were involved with. This is ONO 4059. And that's in the hand of the first patient to receive the drug, who's one of my guys with 17p deleted CLL, who's still on drug 2 years later. It works in exactly the same place as ibrutinib. It targets exactly the same thing. It's a slightly cleaner drug in that it has fewer off-target effects and seems to have a lot better side effect profile. Ibrutinib does not have a bad side effect profile, but this drug doesn't have bleeding, for example, and doesn't have much in the way of diarrhea, so fewer side effects. What about efficacy? Well, here's the poster I gave at ASH, showing look very similar to what you see with ibrutinib. I can't show you the update on this, but over 50 patients have now been treated with lymphoma, and it pretty much mirrors what you see with ibrutinib. So you see good responses in mantle cell lymphoma, you're seeing responses in Waldenstrom's, and of course CLL I'll show you in a second. So it's very, very similar. That drug's just been bought by Gilead, so you're going to see combinations almost certainly of PI3 kinase and this BTK inhibitor coming to a clinic near you soon, I would imagine, I hope. This is the same drug looking at the CLL population, which Gilles presented at ASH as an oral presentation. So ASH are more interested in CLL than lymphoma, and extremely impressive results. So only one patient not responding, and again, very, very good side effect profile and very durable. So the first two patients I put on this drug with CLL are still on drug now. So very, very interesting and important. Another BTK inhibitor, this is CC292. This is the Celgene BTK inhibitor, which had actually been around for quite a long time. What was quite disappointing with this one is in the phase 1 study of this drug, there was no activity whatsoever in the first 2 dose levels. As the dose was pushed up, you start seeing responses, but it took twice daily dosing before you got decent responses. This drug probably isn't going to go too far, because the ONO drug I've showed you and the ACP196, which is just going into clinical studies, looks very like ONO. So these are very well tolerated once daily oral therapies with few in the way of side effects. So it's quite a difficult space to think where you might take your drug long term. There are some studies with this drug plus lenalidomide, as you might imagine, because this is the Celgene drug, and it's a bit early to say much about that. Now, here's the emerging thing with BTK, and that's resistance mechanisms. Better worked out in CLL because the tumour's more accessible than in mantle cell lymphoma. But what's being seen, and I guess it's not a surprise, is mutations at the binding site. And when you get a mutation at the binding site, the drug clearly doesn't bind, and then you lose efficacy. Just to say that the BTK in CLL and mantle cell lymphoma is not mutated, it's normal. So this is a mutation that occurs on drug. This is in CLL, and you can see mutations seen at the binding site, but also some downstream mutations as well. In mantle cell lymphoma, this hasn't been seen. So this binding site mutation hasn't been seen, but we are seeing mutations downstream, and there was an oral presentation at ASH, which I'm just going to show you here, which looked at mutation analysis in patients who were primary resistant and patients who are responding to mantle cell lymphoma. And you can see, looking at this list of mutations here, that clearly the fewer mutations you had, the better response you were going to get. So perhaps this will help us in the future decide which patients should or should not receive these drugs. But it's very early in this phase as to where we are. Okay, so I'm actually going to finish a bit early. Please, John, he's got to get a plane. So in conclusion, BTK inhibitors are highly active in CLL mantle cell lymphoma, as I think I've shown you. They are very well tolerated. Ibrutinib is an extraordinarily well tolerated drug. And when I say the next generation are better tolerated, it really is, you know, these are minor issues in many ways. There doesn't appear to be long-term toxicity. So we're not seeing an emergence of side effects in patients who've now been on the drug 4 years and beyond. Now, combinations are being evaluated in chemotherapy, and there are about 70 things if you go on clinicaltrials.gov of combinations with ibrutinib and chemotherapy, and of course some of the newer agents as well. Newer BTK inhibitors, as I said, are coming into trials, and there's going to be some very interesting studies in the next few years because the companies that are buying the BTK inhibitors, you may know that Pharmacyclics was bought by AbbVie 2 weeks ago, so John's going to talk about ABT199 in a minute. So that company now owns both of those drugs, so we're going to see that combination. John's doing that combination, so am I, later on this year. And Gilead having the Ono BTK inhibitor and PR3 kinase inhibitor, you're going to see that combination as well. So novel combinations are going to be coming quite quickly. There is resistance emerging, and I guess that is the rationale for looking at combinations, particularly of novel drugs. And if we take an analogous situation, something like TB or HIV, using combinations of drugs, that same approach is very much what we have to think about now with some of these hematological malignancies. And I'll just finish by saying it's very important that we put patients into clinical trials with these drugs. Ibrutinib is now available at a relapse situation. Certainly in my country, UK, right now, you can prescribe ibrutinib at first relapse in mantle cell lymphoma. And it's a shame. We need to be learning more about these drugs, so we need to put people into studies, particularly in combination. So I'd encourage you, if clinical trials are available, to consider them, certainly for your patients. And with that, I'll finish. Thanks very much.